neighborhood public sanitation that can influence their innate and adaptive immunity. It can affect their epigenetics, it can affect their comorbidities. There was, based on National Health and Nutritional Survey, Blacks and Hispanics are 1.3 to 2 times more likely to have a pathogen burden, any disease. I mean, this is astounding. I will give a simple example, like for diabetic foot infections, which we see commonly in our hospital. They can sometimes lead to osteomyelitis and resulting in lower extremity amputation. They did a large study where it showed, despite your diabetic severity, Blacks and Hispanics were more likely to get amputation versus whites. So again, this is a common condition we see all of us.
Oh, Dr. Butt, you muted yourself in the middle of that.
Okay,
I know we tend to speak with our hands, so we speak with our hands and then boom.
Sorry. So yeah, I was talking about diabetic foot infections that despite the diabetic severity, Blacks and Hispanics are more likely to get amputation versus whites. And we see similar trends in sexually transmitted diseases, chlamydia, gonorrhea, primary, secondary syphilis, much higher rates in Blacks and Hispanics compared to white. And for HIV as well, so there are 1.2 million people living with HIV in US, and 70% of this is males who have sex with males, MSM, and 30% is heterosexual contact. But Black MSMs are at highest risk, and even the new infections are the highest, 41%. So what does this mean? Mostly people think that this is because of their high risk behavior, but that's actually not true. They had a huge study with 20,000 participants, Black MSM versus white MSM, and actually they engage in same type of high risk anal sex behavior. And actually Black MSM probably had less sexual partners, but the likelihood to have HIV and STD were much higher in Blacks. So it's really not a racial issue, it's social determinants of health. So poverty, homelessness, unemployment, that's what drives these situations. In fact, I think 1 in 3 Black MSM are living with HIV versus 1 in 6. So that's double the rate in Black MSMs, pretty high. I like this quote by sociology professor Dr. Hayes. She mentioned that we are all in the same turbulent waters, but our ships are very different. And she showed a picture of a rackety boat with like pedals versus a huge cruise ship. So we really, there's huge disparities. And we're seeing similar situation with COVID. So there are not really any national data as such on race, but there was a recent study which showed there are about 22% counties in US which are Black, but the deaths due to COVID cases is more than 50% in Blacks. And when you look at, people talk about a lot of underlying diseases, diabetes, coronary artery disease. When in this study, it was not associated, the underlying disease was not the cause of more COVID deaths based on race. So it did not matter. And I feel like there's the reasons behind the COVID cases, and it's shown in the study, was unemployment, access to care, number of people living in the house. So there's a lot of privilege and health as well. So this was very interesting data that I had to look up for this talk. That in Manhattan, there were some place in Manhattan where 40% of people living there left Manhattan between March and May because of their wealth and privilege, because they could to avoid COVID, because they have secondary houses somewhere. And of course, those people didn't get COVID. So all the communities of color that were left behind got COVID. So that's a huge privilege to have. There were, the only data I have is from Mississippi and Tennessee, because they had their, the population and the COVID rate. So one county in Mississippi where there were 38% Black population, but 60% deaths were because in Blacks. And same with Tennessee, 50% of the population was Black, but deaths due to COVID, 70% is seen in Black. So huge disparities. And this is not new. We have seen this with HIV, and we have seen this with even swine flu in 2009 and 10. So these disparities, they keep coming up. And again, interestingly, regarding COVID, this study is not yet published. So it's a VA cohort of 6,000 patients. And all these patients with COVID, there was no difference in death based on race at all. And why is that? It's because possibly we health system has more health equity. So we are not seeing that racial disparity there. So again, it's not really racial disparity, as I said, it's lack of health insurance, lack of access to care, but we see it as disparity. The other thing, which we only talking about it because in Indiana it's a big issue. We go to Scotts County where there's been big outbreak HIV, Hep C because of injection drugs, and the whole community is white there. And but they are unemployed, unstable housing, and all of this. But even the opioid epidemic in US is driven by race. So why we got here is because doctors are much more likely to give opiates to white person than a person of color. And this is how we got in this situation. So to me, it's, you know, it's basis of everything. These social determinants of health are basis of everything. And then there's gentrification. So a lot of times in certain places, so they have done this in San Francisco, trying to decrease their HIV rates, which we have seen tremendous improvement, but it's multifactorial. So the rates improve because of all the effort, but also many of the Black MSM in that area, they left the area because they brought in more affluent businesses, more wealthy people. And because of that, the poor population slowly left. There were about 200 Black MSM that left those areas of San Francisco. And of course, their HIV rates dropped. Now, because the whole population that was at high risk for HIV just left, so you kind of shifted your epidemic out of that county. And again, same gentrification we're seeing in Manhattan with this COVID situation. So I think, yeah, these are really the main things I want to talk about. If you guys have any questions, I'm happy to answer.
Thank you, Dr. Butt. I don't see any questions right now in the chat, so I will proceed to introduce Dr. Marcelin.
Okay, so there's definitely a lot to unpack with these disparities in COVID-19, and I wanted to go into a little bit more detail of what we're seeing. I will throw into the chat box a link to a website called the APM Research Lab that has been collating all of the data, statewide data that has been published by the different county, state and county health departments that include race and ethnicity as part of their COVID-19 reporting. And so they have put all of that information together on this one website, and with all of the age adjusted and aggregated and available data that they are able to find, there's a lot of really stark differences in numbers that I wanted to share with you. So the first is when you're considering the rates of death that are occurring amongst Black people in the United States, it's 2.3 times higher than the rate for white and Asian people in the United States. It's 2 times higher than the rate for Latinx and Pacific Islanders, and 1.5 times higher than the rate for Native Americans. So what do all those numbers mean? It means that one in about 1,450 Black Americans has died from COVID-19, and one in about 1,950 Native Americans has died from COVID-19. And those numbers just, when you think about those in the context of what are the numbers of white Americans who are dying from COVID-19, it's about 1 in 3,350. And so there's definitely very stark differences that we're seeing. And when you account for the rates of people dying over the period of time that they have died since this pandemic began, comparing if these individuals in these minority groups had died at the same rate of death as whites, we would have seen 16,000 Black people, 2,200 Latinos, and 400 Indigenous Americans would still be alive today. And when put that way, I think it's represents really stark differences. And when we adjust for the age differences, and so one of the things that we were seeing in the beginning with COVID-19 was that age was one of the biggest factors it's in terms of risk markers for severity of illness and death. And what we're seeing is when we adjust these deaths for age, that actually widens the gap in the mortality between all of the different race groups and whites. So then compared to whites, Black Americans will have a death rate that is 3.8 times higher with age-adjusted rates versus 2.3 times higher when you don't adjust for age. And put another way, if you are Black and are exposed to COVID-19 and you are younger, your likelihood of dying would be similar to that of a white person who is much older. And I think one of the big questions that people ask when we talk about these sort of data is why. So there is not a biological reason that has been determined to be the cause of this difference. There is not a gene that Black people possess that puts them at higher risk than white people or other races. So what it all boils down to is structural racism. And structural racism is all of the societal effects that have been put into place that maintain a status quo such that one group of individuals is continuously disadvantaged versus another group of individuals. And we have seen over 400 plus years of this playing out in the United States when, thinking about the period of enslavement that happened in the US all the way through to abolishing slavery and Reconstruction and Jim Crow and the Civil Rights era. All of the things that have been passed down throughout those times have played some role in perpetuating structural racism. So I'll give you an example. In Omaha, where I live, there had been redlining of the communities in the 1930s. And what that means is that there were certain communities that were, if you were to draw them on a map, there was literally a red line that was determining on one side of that line were housing that was desirable, and on the other side was housing that was not desirable. And there were different grades that were attached to the different counties in the city, and the counties that were received, the zip codes that received the different the lowest ratings were the ones that were only allowed for minorities and Black individuals to live in, whilst the white Nebraskans would live on the parts that were higher desirability from the housing standpoint. And so real estate agents would preferentially give better options to the white Nebraskans who were looking for housing than the Black ones. The banks would not loan any money to the people that were living in the Black communities versus in the white communities. And so therefore there was not an opportunity to develop and maintain generational wealth building. What that means is resources were not being poured into those communities. Therefore, the schools were not the same standards. The hospitals were not the same standards. They did not have access to the food that was needed to be able to take care of their health. And when you think about it in terms of what is available for healthcare, we know that there is data that has been published that has shown that in communities that are segregated, one study was in Washington D.C. The hospitals in the Black areas were providing care at substandard rates versus the care that was being provided in the white areas. So what does that mean when you are faced with a pandemic and the information that is being provided says, in order to protect yourself, says to stay home and work from home? Well, only about 20% of Black Americans can actually stay home and work from home. About 9 out of 10, there was a McKinsey report that showed about 9 out of 10 of the essential worker jobs were actually staffed by Black Americans. So they can't work from home. They're in jobs that are putting them in a situation where their pay may not necessarily be guaranteed if they are sick. So that means that if somebody at home is sick, that person is more likely to go into work anyways, because if they stay home from work, even though they may haven't had an exposure themselves, or they may be the ones who are sick, they cannot afford to lose that job, because that job is tied to their insurance, and it is tied to the food, it is tied to the everything else that family needs to survive. Multiple families may be living in one housing unit together because of intergenerational housing, and all of that increases the likelihood of being able to pass on the virus within small minority communities. So when we're thinking about what these disparities actually mean, it's really important to consider them in the context of structural racism, rather than shifting to what is a lot easier, which would be finding some reason why inherently or genetically Black individuals or Latino or Native Americans would have higher rates of disease and death. Because even when you look back to the risk factors like heart disease, hypertension, any of these other things that have been seen, yes, there are increased rates of these conditions in those minority groups, but the reasons for those increased rates also point right back to structural racism and access to care. And so we really we cannot have this conversation about disparities in COVID-19 or disparities in any of these health-related conditions without really reckoning with the impact of structural racism on these communities.
Very much, Dr. Marcelin. Let's see. It looks like we're still good in the chat. So Dr. Zimmer, you're next.
Thanks. Thanks again for having me. It's great to be here. I am going to shift gears a little bit, but talk about something that's very related to what I think probably you've heard referred to as the two pandemics. So we have a COVID-19, the SARS-CoV-2 virus that's causing a pandemic, and then we have heightened experiences of racism and violence, especially in Black communities, especially related to conflicts where police brutality has led to deaths, prominent deaths. And so the violence and the pandemic of racism has also risen at the same time. Not that it wasn't existing for the 400 years that we've been talking about, but that they've been both of these pandemics have been coming to a head at the same time. And in my role in education and diversity, I see this impacting our medical students in a really detrimental way. And I thought I would just kind of talk about the groups of medical students from the clinical students down to the pipeline. And the reason that this is so important and actually tied to disparities in health is that we know that the lack of diversity within the physician workforce actually impacts and contributes to the disparities that we see in health outcomes. And the impact that racism is having, the pandemic of racism and the pandemic of the virus are having on our medical student pipeline could also worsen these disparities down the line. So clinical students back in March, mostly across the country in mid-March, were pulled out of the clinical environment and required to stay at home. And just like workers don't always have the ability to work from home, students don't always have an even playing field in terms of being able to study from home and learn from home. Things that impact students who have different access to internet, to computers that are working as well, to being non-traditional students who might have families at home and would be distracted by caring for small children if they were at home as well. On top of that, of being sidelined from the clinical environment and the pressures that were associated with that, our students then also experienced the cancellation of their STEP exams, often randomly with no notice, some of them showing up at the testing center and having step 1 canceled or step 2 canceled. It happened to a medical student, a Black woman in my school this week. And students then don't have the same resources to say, well, I'll fly anywhere in the country to be able to take this test. They're often looking at scrambling into other testing centers within the same state, which puts them at a disadvantage during the upcoming interview season. Looking into the interview season, because of the COVID pandemic, the decision was made to cancel away rotations and also to mostly hold interviews in a virtual fashion. This has disparate impacts on, has the potential to have disparate impacts on students of color because of differences in their ability to do away rotations where they're very dependent on their performance rather than on some of their STEP scores in order to get into competitive specialties. So students who had been planning to make up for slightly lower STEP 1 scores by doing away rotations and doing audition rotations are not given that opportunity. Similarly, when you think about interviewing through a virtual media, you think about the coaching that could happen, access to a background that is professional, and help and coaching with how to handle a virtual interview is something that many times our students who are coming from vulnerable populations, and I'll include our first generation students as well, where the disparities in how they're going to be able to participate in this process is amplified by the pandemic. In the preclinical students, sort of shifting to those students who are really in the basic science years of their curriculum, similarly, they all had to go virtually by mid-March, and they had many things canceled. Clinical rotations where they do shadowing and try to figure out what type of specialty they're interested in. The ability to engage with curriculum when maybe they didn't have a stable internet at home was really difficult. On top of that, in many schools across the country, the campuses were shut down, so students who depend on being able to use library resources were not able to access the libraries, further widening the gap in their potential academic success in the medical school. These students also often had multiple people living in their home or were forced to return to live at home with their families, which increased their risk of contracting COVID-19 as well. In fact, the small number of cases that we've seen among medical students has been in students who had to return to a crowded home environment and were not able to really isolate in a single apartment. I also think a little bit about the pipeline. So what's happening to our pipeline of students who are applying to medical school right now? The shutdown of testing centers for people who are taking the MCAT has impacted our minority students more significantly, again, for the same reasons that Step 1 did. Many of them were counting on that repeat test to boost their application that last time before they applied. Many of them were looking for opportunities to have mentorship on the campus or shadowing experiences or research experiences on the campus, and those things have been shut down in most of our campuses across the country. That, again, disproportionately affects first-generation students and students who are underrepresented in medicine who may have had access previously to summer pipeline programs. We're trying to do, I don't like to paint all the doom and gloom without also talking about some solutions. So structural racism, the same structural racism that contributes to the disparities that we're seeing in the COVID outcomes, also contributes to the disparities we see in these educational opportunities. And so ways that we can overcome that is to maintain access to programs like these pipeline programs, even in the midst of the pandemic. So while other programs are canceled, figuring out ways, as we have tried to do in Colorado, to keep open the ones that are targeting recruitment and support of students who are underrepresented in medicine. Increasing our scholarships at this time is another way to increase the support for students who come from underrepresented backgrounds. Increasing virtual mentorship, and that's something that I would encourage all of you to do, is that if you have opportunities to reach out to students and become a virtual mentor, this is the time to do it. Now more than ever, our students who come from vulnerable populations are at increased risk for kind of falling through the cracks, maybe not seeing medicine as their future, and this is a time that we can step in and kind of solve this problem for them. Looking at our admissions process to say, where does the MCAT really fit in? Do we have to have the MCAT this year in the same way that we've had it previously? Can we make exceptions to our students, especially students who have had tests canceled, or are we gonna dig our heels in and say, well, this is the way you do it, this is the merit you have to achieve in order to come? I think there are opportunities for us to look at our admissions processes. Let's also wrap our arms around our students who are applying to residency training programs and provide them coaching around what that virtual interview looks like. We can do some practice Zooms with them, make sure we have access to libraries where there's strong internet, where we can help them with the computer, show them the background, make a standardized background that represents your school, help them with their appearance on the camera if this is going to be something that they've got to do, which is more difficult to navigate. And then also campaigning and advocating at the national level to increase access to testing for their on campuses so that they can complete their graduation requirements and step requirements, and that we can actually do virtual rotations for some of them. So those are just some of the things that you can do to overcome some of these disparities that COVID has put onto our educational system. That second pandemic of the increased burden of the pain that comes from racism that we've been seeing across our country also disproportionately affects our minority students. In the same way that our Black faculty have been impacted differently, our students are also carrying this burden. They are carrying the burden of the pain, of the tears, of the heartbreak, while also trying to go through the rigors of medical school. And acknowledging that the experience that they're having is something that medical schools and residency training programs need to do. They need our support right now, and they need some space to be able to process what's going on. We need to pair faculty members with students to support them through this. Many students came to me after the shooting of George Floyd and said, my classmates are still studying. They're still studying for their steps. They're still practicing for their for their orthopedics boot camp. And I'm burdened with the pain of my community really literally having a knee on their neck. And I think acknowledging that extra pain is something that we need to do as a community, and really asking them, how are they coping and how are they dealing with it, and giving them some credit. Because people who've experienced this and have the resilience to come through these times are going to be the most amazing residents and fellows and future faculty members. And we need to acknowledge the value that that brings to the future physician workforce.
Thank you very much, Shanta. That was great. And thank you to all of you for bringing a great perspective to our talk today. I have some questions that I would like to ask you. And at the same time, I encourage those individuals that are joining us as part of this group and audience to ask your questions through the chat. And if you want to speak, I'd be happy to mute yourself and show yourself on video so they don't feel like they're talking to the clouds out there. So the first question that I have, Dr. Butt, is Can you talk a little bit more about what Indiana looks like at this time in terms of the COVID-19?
Yeah, so we don't really have any personal data for race, but I got some data yesterday from, this is just IU Health, so it's not truly Indianapolis. It seems like, we had 80 cases in Black and 60 cases in white, and seems like the mortality was almost exactly similar, which kind of troubles me, this information, because it's just by numbers. So, I mean, you have to see how much of the percentage of the population is actually Black, and then they're getting, I understand they're trying to say they're infected the same exact rate as the white population, but that's truly not right, because they're less of the population, but they're getting the same type of infection much more. And just like Dr. Marcelin mentioned, we are seeing younger people. So it's same for Hispanics. And this is my personal experience working at Methodist, that we're seeing a lot of younger Hispanics and Blacks, not only just getting COVID, dying of COVID, which is very hard to see. I've seen people which are much younger than me and really didn't really have much medical problems. So it's not like, as I said before, we keep talking about these underlying health conditions. And these people are coming with COVID cases and dying. And most of the time, not only them, almost always when we see a person of color with COVID at Methodist, their family members are also admitted. And some of them have mild disease and some have severe, but it's impacted the family. And it also impacts how we, like, this is an evolving process, but to get consent for COVID when it started, like for the studies that we're doing, convalescent plasma, IMAB, remdesivir, we didn't even have consents in Spanish, which was a big problem. So many people had to wait to get these drugs because we didn't even have Spanish consent. So there was a lag. Now we have caught up, but it took a while to get there. And this is disturbing. And similar to like discharge. So we have a program where discharge to home, where we can send people who can go home, and we are monitoring them, and nurses call them every day. Again, same issues. Not everyone has internet connection or a smartphone where you can actually talk to them every day. So the idea is letting them go. We may lose them and they may get sick, or may live with multiple other people in the house, which they can infect, and then it's a cycle which is hard to break. So yeah, I feel like there's too many layers of this disparity. And I don't know if in this evolving situation what we can do better. As a physician, you mostly feel helpless at times, because I think the root of the problem is policy making. We need to start from the beginning to fix this problem.
Thank you. Dr. Zimmer, is Colorado in the same type of position?
Yeah, I think that a lot of times people think Colorado is not a diverse community, but we're not as diverse as some other parts of the country from a race and ethnicity perspective. But in our university hospital, which is usually does not have a large underrepresented population, during the COVID times, where we were the largest hospital, largest number of cases in the state, 80% of our hospitalized patients were non-white. During usual times, the opposite is true about our hospital census. About 20% of our hospital census usually is non-white. So during COVID, 80% of our patients in the hospital were non-white, and 45% of them used interpreter services. This disparity also was an additional burden on our faculty, and ultimately, when the students came back, our students of color, because they were facing on a day-to-day basis the increased pain of the disparity of their patients, and recognizing, my husband is an ICU doctor and he's originally from Mexico, and seeing patient after patient after patient who was from Mexico or who had a Latino background and was suffering with COVID, with many of these same stories: not able to work from home, worked at the airport, worked in food services, worked in landscaping, not being protected by their workforce in terms of wearing masks and being allowed to stay home. Those types of disparities kind of were in the face of the faculty and the care providers as well, and contributed to the burden that it was for them to care for patients during this time. I do think that we need to address the systemic problems that led us to this position, and we can't stop. We can't say like, oh, COVID is over, and so all of those differences. What COVID did is it called attention to the health disparities that exist because of structural racism. It didn't create them. It just called attention to the ones that were already there.
Thank you. Thank you. I want to give an opportunity to Dr. Haley Pritchard. She had a question. Haley, are you with us?
Yeah, I'm here. Hey, so the question is actually from Dr. William Frick, who's one of my residents. We're watching this from our team room at University Hospital on the ID service. He wanted to ask the question, so I will let him take the lead.
Yeah, so I was just saying, like, at least at Eskenazi, I don't think here at university, but at Eskenazi Hospital, we still report on our BNPs, race-adjusted EGFR. There's been a lot of talk about this lately. It's one of many kind of race-adjusted parameters that get reported out. And I realize it's a complicated question. It's not just as simple as saying, we're undertreating Black patients, because overtreatment is also a problem in its own right. But like Vanderbilt recently did away with race-corrected EGFR, which I think is evidence that, big institutions are capable of doing it. And I was just curious if you have thoughts on that.
Dr. Marcelin, do you want to go in first?
Yeah, I think it's a great question, and it really, the race-adjusted EGFR, as well as the race-based spirometry readings, like all of these things were based on just like eugenics and this concept of race-based medicine, where Black people were fundamentally treated as different, and there had to be ways to justify the different treatment that then led to statements like their kidneys filter differently. And I'm really excited to see a lot of the movements that have been showing that this is not really based in evidence that supports these practices, and that we need to acknowledge the role that healthcare institutions and the system of medicine has played in perpetuating this type of systemic racism. And so doing away with it is a great first step. And there are a few other institutions that have done this. And then I know even I think at UCSF, they're trying to do it. There's a nephrologist, Dr. Vanessa Grubbs, who wrote a fantastic book. I think it's called 100 Tiny Fingers or 100 Interlaced Fingers. Now I can't remember the exact name, but she talked a lot about that in her book, and the impacts that it has on being put on the transplant list for African American patients. Here at UNMC, we are still using this system, but we have a few medical students who are working with our nephrologists to try to make some changes on that. And as I said that out loud, I wanted to really take that opportunity to call out the fact that a lot of this work that is being done with respect to equity and change in our medical establishment is being driven by medical students. I mean, I have never seen so much activism as I have now. I know that it's always been present, but I wasn't aware about how much work that medical students put in to a lot of these types of activities, and they don't get enough credit for it. Frankly, they should be paid for the stuff that they're doing, because they're doing it on top of doing their schoolwork and all of these other things, but they just want to have a better world, and we should really be those of us who have gone beyond medical training and are, in residency and our faculty should really look at our students and think, well, let's all have some of that energy to be able to push things and make change. Because once we all commit to the roles that we can play as individuals, we can move things really, really far. So I just wanted to make a plug for med students for doing that work.
Dr. Zimmer, you mentioned that Colorado is doing something. Are you, can you briefly say what you're trying
Thanks
to
for this. Yeah, thanks for the shout out to the medical students. And they are leading all of these changes, and residents can do this too by asking these questions and challenging us. Why do you make this adjustment to the GFR? Explain it to me. And I think that's where a lot of these changes come from. Colorado is also examining the EGFR and moving to make the change to not use the adjustment any longer. We also have asked our pulmonary division to look at the adjustments made to PFTs and to revisit the populations that were studied and to make sure that they get ready to make that change as well. I think we have a number of potential areas where we in medicine can lead in this space. The students have demanded it from us, so we just received a list of demands from our Black Student Collective. They had 83 demands. One of them included getting rid of the EGFR, and I gave them feedback and said, let's take this a little bit further and say, let's look at all calculations that we're doing and adjusting for race, and remind ourselves that race is a social construct, not a biological one. And if we're going to talk about biological differences, we need to understand the biology, not the sociology to those differences.
Thank you very much. Dr. Pritchard's team over there at university, was that answer satisfactory over there?
Yeah, thanks for discussing it. There's another book on this topic that's mentioned, Breathing Race into the Machine, that's about this barometer. It's interesting for anyone who's interested in this topic.
Thank you.
Thanks.
Thank you for asking the question. Dr. Ariba Kara also has a question. Ariba, you want to go ahead?
Sure. I'm not in Iceland. Those are thank you guys so much for educating us and speaking your truths. And I think part of this question that was asked earlier answers my question. It feels like we're living in the middle of a tragedy that may also be a big opportunity. And I've never seen as much commitment, certainly from the students and the learners who have been amazing, but also from leadership and the institution. And I feel like as physicians, we tend to focus on what can I do and an individual responsibility that is important. But what else should we be asking our institutions? Like, I would love to see the 83 demands that the students made. Like, what should we as physicians be asking our leadership that is listening right now to say, hey, we want to do something different. What should I ask for? What else should I ask for that I'm not thinking of?
Are you, just to clarify, Dr. Kara, are we talking specific about ID? Are we talking specific about, things like, again, PFTs and
all of it?
Oh, you're covering.
If we had no constraints and we said this is our one shot, one opportunity, and I know I'm sounding like Eminem, but this is it, and we have people who are going to do this for us, what should I ask for?
Well, it's always a good day in my book when somebody quotes Eminem. I would say also that, for the faculty that we have joining, and I know that I see some students, et cetera, that the students at IU also made a call to action, and they have an extensive list of items, as well as the SNMA, as well as the Diversity Council. So we should actually group all those together so our School of Medicine can be fully aware of what all those different groups are asking. But go ahead, Dr. Zimmer.
I put a link into our most recent document that the students came up with. And I would say things that need real change, there are things that will be immediate, that they want to see action on right now, like transparency or changes to admissions committees or representation, payment for contributions to diversity initiatives. Those are kinds of things that you can do immediately. And I think you have to do both structural things and immediate things. We need to do immediate things so that we let them know that they're feeling that they're supported and that we're listening and that we're making changes right away. At the same time, we have to do structural things that take longer. A lot of times students will say, I want there to be more Black faculty at the University of Colorado School of Medicine or at any of your institutions. And all of us faculty know that takes a little bit longer. We need to recruit them. There's, oh, by the way, a hiring freeze. Well, could we make policies that say we won't freeze the hires of diverse candidates? We will only freeze hires of other candidates, but if we have a very strong diverse candidate who needs to come to the institution, we will undo the processes. There are always people who can undo those types of things. Talk to the dean and make sure that that can happen. Make sure that as funding is getting cut from programs, that it's not being cut from diversity programs, that it gets a bubble around it that protects the diversity initiatives, and use the health disparity as a way for doing that. Our students have called for changes to the campus police. They want changes now. And so, some of those things may also take time. So what are the things that you can do to set up a dialogue early on, or to make some changes immediately, doing away with certain practices immediately? So I try to balance, look at the entire process sort of from the pipeline in, the acceptance to, the clinical rotations, and then joining the residencies and faculty. And each of those little steps along the way, there's probably something we can do now and something that we can do that's structural. And that's sort of the approach that I'm trying to encourage us to take here.
Yeah, I would also add, Dr. Kara, our fourth installment of this, which will be at the end of July, will be actually a document that I prepared in conjunction with a few other colleagues from Mount Sinai, Arizona, Yale, and Dr. Zimmer also contributed in checking that. And it's about 40 things faculty can do to advance racial equity in academic medicine. And we will be discussing actionable items from that faculty framework. But I also, as School of Medicine Diversity Council, I will make sure that we co-chair, that we make sure that we are putting all these calls to action and things that our students want in one document, so all of our faculty are fully aware of this. I also realize now that it's 4:58, so I want to thank you all for a wonderful conversation about racial disparities in infectious disease. There's an opportunity to ask one more question, so I don't know if there's anybody else out there that it's dying to ask a question. I do believe that one of our participants actually had a really important question, and it was related to the discussion of systemic versus institutional versus structural racism. So I would like to open that up for discussion. I know that many times systemic and structural racism is used interchangeably. We tend to think about systemic more in terms of across society, and then these normalization of racism practices that are quite dynamic, but in the end, obviously disadvantage minoritized group. But we're looking at it in a larger system. We're looking at it from public, policies, institutional practices, and things of that nature. It also includes talking a little bit more about the historical context of the certain situations, as opposed to institutional racism, which we are really clearly talking about racism that occurs within the institution, where individuals with power are actually perpetuating a negative environment for those that are disadvantaged in those institutions based on their race. Hopefully that answers the question about the difference between these three. Anything that our panelists would like to contribute to that clarification? Okay, So Dr. Oh, let's see.
I was just answering the question that was
Oh,
typed.
okay. You did? So we're good? Okay. Thank you. So thanks again for participating. Thank you all who joined. Stay tuned for our next installment. And again, I appreciate our wonderful conversations today. Thank you all.
Thanks for having us.
Bye, guys.
Bye.
Bye, thank you.